NutrEval Test Interpretation, Test Overview, and Case Study Review with me, Stephen L. Goldman, part of the Genova Diagnostics Medical Education Team. Objectives of this presentation. By the end of this presentation, you'll understand each section of the NutrEval. You'll distinguish functional recommendations from directly measured recommendations. You'll be aware of two types of NutrEval, the NutrEval First Morning Void and the NutrEval Plasma Amino Acid. So the NutrEval Plasma Amino Acids reflects amino acid findings over about a 24-day period of time, more of a steady state. The NutrEval with First Morning Void amino acids speaks to the dietary intake of protein over the last 24 to 48 hours. You'll be able to utilize pattern recognition when you analyze the test findings, which is an important tool in regard to really getting a sense of what are the take-home messages the tests provide. And we'll get into that in some detail, especially with the case study that lies ahead. And we will utilize the NutrEval findings in a case study format. Introduction to NutrEval concepts. Functional versus direct measurement. A basic principle of the test is functional versus direct measure. We're accustomed to direct measure of an analyte. For example, if we want to get data regarding the patient's need for folate, we could do a blood draw and directly measure the amount of folate. We would then compare the level to a predetermined reference range. In a functional recommendation, such as on the NutrEval, we do not directly measure folate. Instead, we look at the various markers on the test that depend on folate as a cofactor. An algorithm is designed to calculate from those markers whether there's a need for more folate. Several analytes are taken into consideration by the algorithm, and they will not all be given equal weight in the recommendation. For example, the organic acid famiminoglutamic acid, or FIGLU, requires folate in order to be broken down. High concentrations of FIGLU dumped into the urine would then indicate a functional need for folate. In this example, there is no direct measure of folate, yet various other analytes help to determine a functional need. Patient populations. What is the patient population that might most benefit from the NutrEval? Well, nutrient needs can be a key element in patients with chronic illness. There are also patients that come to your office with bags filled with supplements in need of guidance regarding a more specific protocol. Nutrient needs are a key component of mood disorders such as depression and anxiety. Remember, serotonin and dopamine have amino acid precursors. Heart disease can be tied to inflammation. Essential fatty acids provide insight on both pro and anti-inflammatory factors. Nutrient cofactors such as vitamins, minerals, and organic acids help to drive the Krebs cycle, thereby influencing levels of energy or fatigue. Pattern analysis. When reviewing a profile with so many individual analytes, it's easy to focus on a handful of individual findings and thereby lose the forest for the trees. There are various patterns that can emerge on the test that provide us with headlines regarding specific areas of greater need. The algorithm is a useful tool for that reason, but I will also point out various patterns as we walk through the test and case study. Clinical utility. There are 5 sections to the NutrEval that provide us with a great deal of data that can be used to hone an effective clinical protocol. We'll look at each of those sections, but combined they can give us the headlines and the more specific recommendations that come with the NutrEval profile. Let's look at the different components of the NutrEval. We start with the results overview. This gives us a good, clear look at some of the findings and is the beginning of pattern analysis in terms of determining what are the headlines. The suggested supplement schedule are the recommendations provided by the algorithm. Of course, the doctor is always going to take these into account along with the clinical presentation. The interpretation at a glance is your tool for a report of findings, a way to sit down with the patient and discuss the findings in a way that they can understand. The Krebs cycle at a glance pathway chart helps us to look at the Krebs cycle, look at that pathway chart, and get a sense of nutrient cofactor needs that can help with imbalance. This is the organic acids page. We'll certainly go into great detail here, but these are the listings of the organic acids tested on the NutrEval. And the amino acids, in this case, are plasma amino acids, and we look at the various essential amino acids, non-essential, and other markers that provide great insight into protein intake and utilization. Here we have the essential and metabolic fatty acid markers from packed red blood cells, and a pathway chart that goes along with that to make it even clearer as far as the omega-6 and omega-3 family and their relationship. And then finally, the oxidative stress markers, which include several ox stress markers as well as elemental markers and vitamin D add-on option. These are the components of the NutrEval. Let's take a look at the results overview page in the front. When we're looking at this, we can see that there are antioxidants listed, B vitamins, and then minerals. To the left, we have our normal green column. So that tells us everything listed here from vitamin A through molybdenum, based on the algorithm, is looking really very good. And so, for example, vitamin A is in green, which means it needs the minimal amount of supplementation. When we get to the next page and we talk about dose recommendations, there'll be a recommendation for vitamin A, but the lowest possible one that we could recommend. Whereas the borderline, I think of as more borderline to moderate in yellow. So that's from alpha lipoic acid through zinc. And so again, when we look at the supplement schedule on the next page, the dosage recommendations will reflect that more moderate recommendation. And then, of course, the high needs are in red. Here we have B6 and B12, a functional recommendation for a high need. Now, be aware that this is a great place to begin thinking about pattern analysis. So, antioxidants, is that a big take-home message? Is that a headline? Well, there's a little bit with alpha lipoic acid, but it's not a big headline. But B vitamins really are. The B1, 3, and 9 being moderate, a high need for B6 and B12. So B vitamin needs really stand out here, as does the need for zinc and manganese. So minerals and B vitamins already from our pattern analysis have a strong need. And so we can see that in our suggested supplement schedule. If we look at this, you'll see a column to the left, which is the daily recommended intake, or DRI, which is a minimal standard. How much vitamin C to prevent scurvy? It's really there just to give us a sense of proportion. The patient's daily recommendations are recommendations based on the algorithm utilizing the test results. So again, the green, yellow, and red configuration. To the right, we have the provider daily recommendations. That's blank, and that's yours. Because in the end, we have this test, we have these findings, and an algorithm with functional recommendations. But you're face-to-face with that patient. So it's always okay to look at that and see what recommendation changes you might want to make. That's the whole idea of utilizing these findings with the clinical presentation. The amino acid recommendations are actually based on a direct measure. So all these recommendations, you see the glycine at 348, isoleucine at 396 in milligrams per day, are based on a direct measure. In the NutrEval plasma amino acids, that'll be a plasma direct measure. And then there's the NutrEval first morning void amino acids, and these numbers will be based on a first morning void urine finding. The interpretation at a glance is your tool for a report of findings, a way of sitting down with the patient and taking this complex test and making it understandable. So we have here at the bottom right a key. The interpret at a glance, by the way, is usually about 3 pages long. You see the key, the function, causes of deficiency, complications, and then food sources. So for example, if you look at the top left at vitamin A, there's that green, yellow, and red indicating that the black X telling us that the algorithm places the patient way to the left in the green, the minimal amount of recommendation for vitamin A. And so the first green function arrow tells us what is vitamin A. The yellow, how may I have become deficient in vitamin A? The gray, what would be the clinical complications? What might I see clinically with a low vitamin A? And then finally, my favorite, the purple, How do I get this from my food? How do I get this from my diet? So you can see that as you go through this with the patient, they can really understand this and have the findings right there at their fingertips. So our key points up to now: there are two types of NutrEval, a plasma and first morning void amino acids. Pattern recognition is a key element of test interpretation. Functional recommendations utilize an algorithm to assess nutrient needs. The interpretation at a glance provides a tool for patient-reported findings. Let's talk about the organic acids section of the test. You see it here on the right. Organic acids are produced through metabolic functions. So remember, organic acids aren't really nutrients. They're metabolic byproducts. Nutrients like amino acids, lignans, flavonoids go down pathways. They're metabolized. And organic acids are metabolic byproducts of those nutrients. They're measured on the NutrEval by first morning void urinalysis. Always urine first morning void on organic acids. And they're categorized into groups based on their clinical relevance. So you see here, for example, malabsorption, dysbiosis, yeast fungal dysbiosis as categories in terms of clinical relevance. The markers are ratioed to the creatinine concentration. That's really important. Creatinine concentration gives us some insight into renal function, but since all of the markers on this page are ratioed to creatinine, we want to have a good level of creatinine so we know we have a good specimen. If we have an extreme low or extreme high of creatinine, that can really influence the findings. So let's look at one of these sections. In fact, we'll look at all of them individually. First, let's look at the malabsorption and dysbiosis markers. Now, if you have a patient with gut issues, this is an interesting point of view of gut function. But the gold standard would be a GI-FX stool 2200 in order to get a really closer look at gut function. But here we can look at malabsorption and dysbiosis markers. You see, for example, an elevation of the 3-hydroxyphenylacetic acid and the benzoic acid. So with the 3-hydroxyphenylacetic acid, for example, we know that there are various nutrients that are related to this particular organic acid. Things like wine and grapes and cranberries and black tea and orange juice, grape seed extract. These are nutrients that can be converted in the gut by anaerobic bacteria into 3-hydroxyphenylacetic acid. And when that occurs, we're seeing a very high concentration. We may wonder about an imbalance amongst the various bacteria that are making the conversion, thus dysbiosis. It could also reflect some degree of malabsorption, because if we're taking in, for example, proteins and other nutrients, and they're not readily absorbed in the small gut, and they linger, that provides more opportunity for those anaerobes to convert the nutrients into this organic acid. The same holds true with benzoic acid as well. So these elevations can lead us in the direction of malabsorption and dysbiosis. Benzoic acid, by the way, is very commonly elevated because it's a very common preservative. If you look at any canned or bottled beverage, you're likely to see sodium benzoate or potassium benzoate as a preservative. Let's look at the cellular energy and mitochondrial metabolites. And I touched on these earlier with the Krebs cycle. So we have carbohydrate metabolism, energy metabolism, fatty acid metabolism, all the various organic acids involved in the Krebs cycle and the production of energy in the mitochondria. So for the Krebs cycle, when we look at these organic acids, just be aware this is not a substitute for a muscle biopsy for mitochondrial function. What we're doing is we're looking at the organic acids in the context of the pathway chart of the Krebs cycle to see if there are any obvious imbalances. And when we see those imbalances, we think about the specific nutrient cofactor support that we could provide. Let's take a look at the cellular energy and mitochondrial metabolites next to the Krebs cycle at a glance pathway chart that we provide on the test. Again, we know that the idea of the Krebs cycle is to take macronutrients, fats as fatty acids oxidizing, carbohydrates through glycolysis, making pyruvic acid and lactic acid, proteins as amino acids making acetyl-CoA, and that those macronutrients provide us with acetyl-CoA, and that the acetyl-CoA is going to fuel in the mitochondria the citric acid cycle. So if we're looking at carbohydrates as they produce pyruvic acid and lactic acid, that looks just fine. But then the pyruvic acid has to make acetyl-CoA. What nutrient cofactors are required for that pathway? Well, everything in the green circle indicates that we're looking at nutrient cofactors that must be there adequately to move the pathway ahead. So for pyruvic acid to convert to acetyl-CoA, we need adequate magnesium, lipoate, B1, 2, and 3. So this is a way that we can look at imbalances. If we had seen an elevation of pyruvic acid, we'd wonder, why is that high? Well, it may be that it would be having difficulty in its conversion to acetyl-CoA. What would we consider necessary? Magnesium, lipoate, B1, 2, and 3. Those would be the cofactors. Now, bear in mind that there is also the possibility that various toxics can block the pathway. So if pyruvic acid had been elevated, and I know it's not here, but if it had been, it may also be that it's arsenic, mercury, and antimony that are elevated, creating a blockage. More typically with toxics blocking a Krebs cycle function, you'll see a more global shift to the right. Let's now look at a second section here, the metabolic analysis markers for neurotransmitter metabolites. Now remember, with the neurotransmitter metabolites, we're tracking metabolites from various neurotransmitter pathways. But these metabolites do not provide direct measurement of dopamine or serotonin or epinephrine. The status of the metabolites can provide data regarding nutrient cofactor needs. So we're not looking at dopamine directly, but we're looking at the pathway, very much like we just did with the Krebs cycle. When I'm doing consults on the phone for this, often I have doctors asking me, what are those various pathways? Do you have a chart? Well, I've heard you out there asking, and so I did create this catecholamine metabolism chart on the right. So on the left, we're looking at the neurotransmitter metabolites. We measure homovanillic acid, and we measure vinylmandelic, as well as 3-methyl-4-hydroxyphenylglycol. So if you look at these various markers on this chart, tyrosine is an amino acid. It converts into dopamine. Dopamine gives us a sense of focus and well-being. So dopamine converts into the homovanillic acid that we look at on the left. At 3.7, it looks fine. But dopamine also converts into norepinephrine, epinephrine, adrenaline, normetanephrine, and then finally the 3-methyl-4-hydroxyphenylglycol and the vinylmandelic acid. By tracking these imbalances, we can get a sense of what might be going on, what kind of nutrient cofactors may be needed to better balance the pathway. The same thing holds true for serotonin metabolism. Again, at your request, I have put together this pathway chart whereby tryptophan, the amino acid, converts, into 5-hydroxytryptophan, which we often provide for our patients to help them sleep. Now, 5-hydroxytryptophan makes serotonin. We often think of serotonin in the brain, but the vast majority of serotonin is in the gut. Serotonin will be methylated to make melatonin. Melatonin helps us with our circadian rhythms, but is also an antioxidant and anti-inflammatory. Serotonin then makes 5-hydroxyindoleacetic acid. In this case, we have an elevation. So there are a few possibilities to consider. If the patient is supplementing tryptophan or 5-hydroxytryptophan, we may expect to see an elevation. If they're on SSRIs, we may expect that. But if there are gut issues, if they're burning through a lot of serotonin under stress, these are the kinds of discussions we can have in analyzing the neurotransmitter metabolites. Understanding the pathways is really key for that. Organic acids provide us with great insight into functional need for vitamins. You can see this vitamin marker section with a listing of various organic acids. When we look at this, we can see there's, for example, an elevation of methylmalonic acid. So how does that elevation of methylmalonic acid provide insight into a specific vitamin need? Let's take a look at the various vitamin markers in terms of organic acids and how they work. You see the methylmalonic acid somewhat elevated. So you have this organic acid. The breakdown of that organic acid requires specific vitamin and mineral cofactors. The elevation of an organic acid may indicate a functional need for specific cofactor supplementation. In other words, methylmalonic acid needs a specific vitamin and or mineral cofactor, in this case B12, in order to be broken down. So if that B12 functionally isn't doing the job, you'll see an increase in the level of methylmalonic acid in the blood, which means it'll get dumped into the urine in higher concentrations. So as we see here, we have a higher level of methylmalonic acid. When we look at specific elevations of organic acids, they provide insight into what specific nutrient cofactor may be required. Methylmalonic acid conversion requires vitamin B12. Elevated levels of methylmalonic acid in the urine and urinary excretion tells us that we need more B12 functionally to better break methylmalonic acid down. Our section on toxin and detoxification markers includes alpha-ketophenylacetic acid, which reveals an exposure to styrene, styrofoam, plastics, exhaust fumes. Alpha-hydroxyisobutyric acid reveals exposure to MTBE, which is a gasoline additive that was used to lower gasoline emissions in the 1990s through the early 2000s. Pyroglutamic acid is both a precursor and breakdown product of glutathione, an important antioxidant and detoxifier. Our key points for organic acids. Organic acids are produced through metabolic functions. They're measured through first morning void urinalysis. Organic acids are categorized into groups based on their clinical relevance. Now we begin amino acids. Here's our amino acids page. In this case, it's an amino acids from plasma. Remember, there's an option to measure in plasma or first morning void. There are basically two types of NutrEval, and this is a dividing point. There's the NutrEval with first morning void amino acids and the NutrEval with plasma amino acids, and you need to order the kit based on that. All other sections of the NutrEval are the same. The only differential here is plasma of first morning void amino acids. Plasma amino acids provide a more steady state measure of levels. So that when you're looking at this, for example, this amino acids plasma, you're looking at a time frame of about 24 days regarding the dietary intake of protein. In a first morning void amino acids test, you're really looking at the more immediate dietary intake of protein over the last 24 to 48 hours. So a steady state comes with plasma. A more recent dietary intake of protein comes from first morning void. You see the nutritionally essential amino acids that come from dietary intake of protein, as well as the non-essential amino acids that come from the conversion of the essential amino acids. And they require certain nutrient cofactors for that essential amino acids conversion. So here they are lined up side by side. We talked earlier about pattern recognition. So when I look at the nutritionally essential amino acids, I'm looking for a pattern. If I draw a line pretty much down the middle here, it would appear that most of these amino acids, all of these amino acids, are to the left of that line. In other words, the overall pattern is of low essential amino acids from the diet. On the right, the non-essentials that come from the essential amino acids are also trending low. So it's not an issue, at least demonstrated here, of the essential amino acids having a problem converting to the non-essential. Their patterns are very similar. This may be more about dietary intake of protein in the diet or an inability to utilize that protein effectively. So let's take a look at that question on the next slide. When we look at the nutritionally essential amino acids, again, the pattern is low. So the question that comes to mind now is this pattern the result of low protein intake? In which case, I might just change the dietary intake of protein, change the patient's diet. But what if they're eating a pretty robust or moderate level of protein and they're just not breaking down or absorbing it well? In that case, I'm thinking more along the lines of enzyme support, HCl support. There are ways to get a sense of dietary intake of protein on the page. I look at the dietary peptide-related markers. Here you see the 1-methylhistidine at 1.06. 1-methylhistidine provides insight into dietary intake of protein from fish, fowl, chicken, turkey, duck, from meat. So when I look at the pattern of the 1-methylhistidine, it's to the right of the midline. It would appear that this patient is eating a reasonably moderate plus level of protein in their diet. That tells me that perhaps the low essential amino acids pattern is more about utilization of protein, not a lack of dietary intake. 3-methylhistidine reflects fibers from muscle, the actin and myosin fibers from the breakdown of muscle. So for example, if you're going to the gym and working out with weights and tearing and rebuilding muscle fibers, this can go up. If you have some catabolic issue in terms of muscle wasting, it can go up too. But if not, it can also reflect dietary intake of red meat. So looking at both the 1 and 3-methylhistidine indicates to me that we're looking at a moderate plus level of dietary intake of protein, but we're not seeing that reflected in the essential amino acids. So it's not a matter of eating more protein, it's a question of whether or not you can utilize that protein more effectively. The urea markers, especially the urea, indicate that they're clearing reasonably well. No issue there. The key points for the amino acids. Amino acids are measured in plasma or first morning void. Plasma measurement provides a more steady state time frame. Pattern analysis reveals status of digestion and absorption. Amino acids are the precursors to neurotransmitters. Essential and metabolic fatty acids from packed red blood cells. Let's take a look at the essential and metabolic fatty acid markers from packed red blood cells. We begin on the top left with the omega-3 fatty acids, and you see them all listed. But notice on the bottom right we have this omega-3 index. The omega-3 index in the literature really provides great insight into the need for omega-3 supplementation. In the literature, the omega-3 index should be between 8 and 10 ideally. Less than 4 would be a serious consideration for omega-3 support. We calculate the omega-3 index by looking at the top left again at the EPA at 1.05 and the DHA at 4.6. The sum of those two is how we got that 5.7 finding. So there is some room for improvement for omega-3 support for this patient. The omega-9 fatty acids are generally judged through oleic, which looks reasonably strong here. I don't typically mind a little bit of an increase in omega-9s. Remember, they come from olive oil, avocado, and do have some anti-inflammatory qualities. For the saturated fatty acids, I'm basically going to look at the very bottom of the page, the overall percent of saturated fats. Here at 39.1, if anything, a little bit on the lower side. We do need saturated fats in our diet. The omega-9 fatty acids are on the top right. And when I look at these, I want to get a closer feeling for both the arachidonic acid and DGLA. So let's take a look at the next page to get a look at both the anti-inflammatory and pro-inflammatory nature of omega-6 fatty acids. The omega-6 family is on the right side of the page. It begins with the linoleic acid at 15.3 and then converts into gamma-linolenic. I know that looks like a Y, that's a gamma, via delta-6 desaturase enzyme, the blue arrow. The gamma-linolenic, or GLA, converts into DGLA, dihomogamma-linolenic acid, at 1.32. Now, DGLA is significant in that it's an omega-6, but it's an anti-inflammatory. DGLA leads us to the arachidonic acid at 15. It's arachidonic acid that, when elevated, creates a cascade of inflammation. That's the one we want to keep moderate to low normal. We do need arachidonic acid for cell viscosity, but we want to keep it in check. Whereas we want to see the DGLA here at 1.32 again which is anti-inflammatory. So my goal on this page basically is to keep the DGLA in the green and keep the arachidonic acid under control. In order to increase my DGLA, I need to use GLA because DGLA can't be supplemented. So in this case, I would think about that second box, the GLA, you see in small letters, evening primrose, barrage, black currant. Those are all GLA sources that I would provide for this patient. I might also consider some of the nutrient cofactors for the enzymes like the delta-6 desaturase and elongase that you see on the center portion of the page. Our key points for the essential metabolic fatty acids are: omega-3 fatty acids function to lower inflammation. DGLA is an anti-inflammatory omega-6 fatty acid. Arachidonic acid is a pro-inflammatory omega-6 fatty acid. Let's look at some of the oxidative stress markers from the NutrEval. You see glutathione at the top here at 1,632, a very strong antioxidant and phase 2 detoxifier. Lipid peroxides and 8-OHDG. Liquid peroxides from urine, as well as 8-OHDG from urine, are really important markers in the sense that they represent measurable oxidative stress damage when they're elevated. And when I say elevated, remember the green and yellow combined are the reference range. But there are times you want to be in the green. I hold that to be true for glutathione, but also for the lipid peroxides and 8-hydroxy-2-deoxyguanosine. When they start to wander to the right into the yellow, that would be measurable oxidative stress damage, and the need for various antioxidants will come up on the first two supplement pages of the NutrEval. And then we have the CoQ10 as well. That leads us to the elemental markers, the nutrient markers, the nutrient elements, which are copper through zinc, and you can see various blood sources. Copper from plasma, magnesium from the packed red blood cell, etc. The yellow is the width of the reference range, and the green is the heart of the reference range, that one standard deviation. To the right, the toxic elements are all measured in whole blood. So you can see that there is an increase in mercury. You'll often see this in patients that have fish as part of their dietary intake. Sometimes we see this in patients that supplement with fish oils that may have some mercury contamination. So let's look closer at the nutrient elements. They're directly measured in plasma, red blood cells, and whole blood as indicated. The direct measure is not the only factor taken into account for dose recommendations. This gets us right back to the first point, the principle of direct measurement as opposed to a functional recommendation. You see the magnesium here at 38.9. It looks just fine as far as being measured directly, a direct measurement from a reference range. But sometimes when you look at the supplement recommendations, you can see a direct measure like this that looks fine, and yet there'll be a yellow or red high need for magnesium. And that's because the algorithm certainly gives the most leverage to the direct measure of magnesium, but will also take into account other markers on the test that require magnesium as a nutrient cofactor. So the algorithm will give direct measurement the most leverage, but other analytes will also have weight in the final recommendation. Toxic elements are measured in whole blood, and the findings provide insight into exposure to toxics. Here are our key points. Lipid peroxides and 8-OHDG reveal measurable oxidative stress damage. Toxic elements specifically measure exposure. The algorithm for nutrient elements takes many analytes into account. Let's begin our case study. The patient is a 36-year-old female. She complains of fatigue. She actually wakes up tired. She describes an overall joint achiness. She has a stressful job as an occupational therapist. Describes minimal exercise, mostly 1 to 2 mile walks, maybe twice a week. And she describes a diet of moderate protein intake and avoids sugar. The NutrEval results overview is our first opportunity to use pattern analysis. So when I look at the antioxidants, B vitamins, and minerals, I want to know, what are the headlines here? Antioxidants? Well, there is a moderate need for alpha-lipoic acid. B vitamins, I think that's a strong headline. The B6, certainly the folic acid and the B12, which also make me think about methylation, key players in methylation detoxification, as is magnesium. When we look at the supplement schedule, in addition to the various needs on the overview page that we just looked at, we also see some moderate recommendations for omega-3 and pancreatic enzyme support. The omega-3, 1,000 milligrams. Look at the pancreatic enzyme in yellow, a moderate need for pancreatic enzymes at 5,000 IU per meal. The Krebs cycle shows no significant imbalances. The fatty acid oxidation looks unremarkable based on a very normal suberik and adipic acid finding. Glycolysis, the creation or conversion of carbohydrates into pyruvic acid and lactic acid, are well within the range. And there are no ketone body findings outside of the reference range as far as the beta-hydroxybutyric acid. When the beta-hydroxybutyric acid is high, then you have to ask the question, why high ketone bodies? You see this in starvation diets, diabetes, alcoholism. You'll see this also in a ketogenic diet. Low-carb diets do create ketones. The organic acids page, or the metabolic analysis markers page, is divided into various functional categories. We start with malabsorption and dysbiosis markers. These all look really very good inside the reference range. This is the section that is often responsible for probiotic recommendations. The cellular energy and mitochondrial metabolites are those organic acids we've already looked at as part of the Krebs cycle pathway chart. Note the creatinine concentration at the bottom left is well within the reference range, so we have a good specimen. We spoke earlier about the various pathways involved in the neurotransmitter metabolites. I would point out, though, that tryptophan does make kynurenic acid in stressful situations like high cortisol or inflammation. But the key is, does kynurenic acid convert into quinolinic acid, here at 3.4. Quinolinic acid is a known neurotoxin, and it's excitatory to the central nervous system and is associated with systemic inflammation. That's why we look at the kynurenic-quinolinic ratio. If it's a low ratio shifted to the left and to the red, that means we're making more quinolinic acid, and that's problematic and tells us that we have to look at inflammation as a key take-home point. These are the vitamin markers. We're going to look at this again on the next slide because we do have an elevation here. Toxin and detoxification markers look just fine. The alpha-ketophenylacetic from styrene and the alpha-hydroxy-isobutyric acid from MTBE tell us that at this point, not any high exposure to those two water-soluble toxins. I mentioned on the previous page that under vitamin markers we had an elevation. Here it is, the femiminoglutamic acid, or FIGLU. You can see it's at 1.8. This is a great illustration of what we mean by a functional recommendation. Femiminoglutamic acid comes from L-histidine, which is an amino acid. So the conversion of L-histidine to FIGLU, and then the breakdown of FIGLU via the cofactor of folate. But if folate functionally is inadequate, then we'll have a buildup of FIGLU, which will lead to greater urinary excretion. So a high finding in the urine for femiminoglutamic acid tells us that there's a functional need for folate. Let's take a look at the amino acids page, in this case from a plasma amino acids finding. On the left, we see the nutritionally essential amino acids. The first thing I want to look for is a pattern. What is the pattern of the nutritionally essential amino acids? Drawing this plumb line tells me that for the most part, we're to the left of the midpoint. So a little bit on the lower moderate section in terms of nutritionally essential amino acids from the diet. How does that compare to the non-essential protein amino acids? Well, I would say the non-essentials are even lower than that. So there may well be a conversion issue. The nutritionally essential amino acids may need nutrient cofactors, B vitamins and nutrients, to better convert into the non-essential protein amino acids. In addition, I want to get a sense of the dietary intake of protein. Does it match up with this less than moderate essential pattern? And when I look at the 1-methylhistidine, I see that it doesn't. 1-methylhistidine is elevated here. That tells me that the patient is likely eating a pretty high protein diet. I know the protein diet that she described was more moderate, but we see evidence here from fish, fowl, or meat that it's higher than that. And yet the essential amino acids pattern does not reflect a high dietary intake of protein. The algorithm will look at this and make a recommendation, a moderate recommendation for pancreatic enzyme support. We look at the amino acids plasma and continue with the intermediary metabolites, the B vitamin markers, which look fine, the urea cycle markers that look good as well. I always keep an eye on the urea here at 497 because a high protein diet should move the urea to a higher level, shifting it to the right. The glycine and serine metabolites also look within the reference range. Now we can look at the essential and metabolic fatty acid markers. And we start off with the omega-3s. And we can see that there's a low omega-3 index at the bottom right at 4.4. Remember, that comes from the top left, from the sum of the EPA, 0.37, and the DHA, 4.1. So that 4.4 finding speaks to a low omega-3 index and a need for omega-3 supplementation. We also see in the omega-6 fatty acids a low DGLA. So that's also a pro-inflammatory finding. Low omega-3s, low omega-6 DGLA. Here's the pathway chart we looked at earlier. Remember, there was a low GLA, so there's little to convert from the gamma-linolenic into the dihomogamma-linolenic. So I would consider GLA supplementation. And you see it in the second box. Evening Primrose, Barrage, Blackcurrant all have GLA to convert into DGLA. The arachidonic acid is really the pro-inflammatory finding when elevated. A high arachidonic acid creates a cascade of inflammation, but this moderate finding is just fine. So the bottom line here is we need more conversion of GLA into DGLA, which means also more GLA. As a result of the low delta-6 desaturase conversion of linoleic to gamma-linolenic, I would also think about the nutrient cofactor findings listed on the center of the page under delta-6 desaturase. The oxidative stress markers look just fine. The glutathione, the lipid peroxides, and 8-OHDG, remember those two are measurable oxidative stress damage when in the yellow or red, and the CoQ10 is moderate, so really nothing here that speaks to supplementation needs. These are the elemental markers from blood. On the left, we have the nutrient elements. So you see copper through zinc listed here. Notice the magnesium is actually a little bit low at 31.6. You may recall that there was a moderate recommendation for magnesium on the front two pages. On the right side of the page, we see the toxic elements. These are all from the whole blood measure. And we can see here the mercury exposure at 8.69 is rather high. Typically, we see this in patients that eat a lot of seafood. Also, sometimes, if you have a fish oil supplement that is not really of the best quality, we'll often see an elevation of mercury as well. So one key thing here to do is find out what's the source of that mercury. Since it's measured in whole blood, whatever the exposure was, it occurred 120 days from the time of the blood draw. After reviewing the findings of the NutrEval, here are treatment recommendations to consider. For her inflammation, support with omega-3 and GLA omega-6 fatty acid supplementation. Follow up with an adrenal cortex stress profile to assess the HPA axis imbalance that we see. Remember, she complains of waking up tired and being fatigued throughout the day. The adrenal cortex stress profile also has the option of a cortisol awakening response, and that would be a great pairing as well. So adrenal cortex stress profile and CAR. Support better sleep. Consider phosphatidylserine 3 hours before bedtime. For oxidative stress and detoxification, alpha-lipoic acid support is indicated. B vitamin support is indicated with a methylated folate to support methylation. Supplement magnesium is indicated on the test as well. Remember, there were digestion questions around pancreatic enzyme support needs. So pancreatic enzymes, possibly even betaine hydrochloride. Consider evaluating the GI tract with GI effects stool profiles like the GI effects 2200. And for diet, consider a Mediterranean-style diet for better balance. find the source of the elevated mercury as well. So here are our key points. There are two types of NutrEval, plasma and first morning void amino acids. When you order a kit, you have to let us know which one you want. Patients with chronic illness require specific nutrient support. Pattern recognition is a key element of test interpretation. Functional recommendations utilize an algorithm. Organic acids are categorized into groups based on their clinical relevance. Amino acids are the precursors to neurotransmitters. The algorithm for nutrient elements takes many analytes into account, and the toxic elements measure exposure. After seeing this NutrEval presentation, my hope is that you'll be able to understand each section of the NutrEval and to distinguish functional recommendations from directly measured recommendations, and to be aware of two NutrEval options, the plasma and first morning void amino acids, and to be able to utilize pattern recognition. And we were able to utilize the NutrEval findings in a case study. Thanks for listening. I'm Stephen Goldman, a medical education specialist at Genova, and I'll see you on the phone.